Sub-Saharan Africa continues to account for more than half of all malaria cases and deaths globally, despite the massive attention in cash and kind resources it has received over the years. Now, since the turn of the second millennium, cases of the tropical disease have been on the decline until the emergence of COVID-19 pandemic, when it began to spike again. In 2019, global cases stood at 229 million. In 2020, when the pandemic hit, cases rose to about 245 million. Now, 2020's jump in figures continued into 2021. During that year too, cases increased by 2 million, resulting in 617 people dying of the disease last year. According to the WHO, the two pandemic years produced 13 million in new malaria cases because of disruptions brought on by COVID-19. What's more worrying is the fact that during this period, Sub-Saharan Africa accounted for 95% of the cases and 96% of all deaths. In fact, 4 African countries accounted for a little more than half of all malaria deaths globally. I'll tell you which countries they are now. Nigeria came up tops with 31.3%. The Democratic Republic of the Congo, 12.6%. Tanzania came in with 4.1%, and Niger with 3.9%. Now, of these cases and deaths, children under the age of 5 are the most vulnerable. So today on The Square, we want to find out what is holding Sub-Saharan Africa's progress back. We also want to ask if we can achieve a malaria-free Africa anytime soon. My name is Keminni Amanor. Thank you so much for joining our gathering. At The Square with us today are Dr. Chukwuma Okafor. He's public health expert, State University of Zanzibar in Tanzania. We also have Dr. Dialent Noble, who is art clinician and founder, Saving Women and Children Foundation. And they'll be with us for the first part of our program today. Gentlemen, you're welcome to The Square.
Yeah, thank you. Good to be on the show.
Great. I'm going to start with you, Dr. Okafor. How would you describe the progress or milestones that Sub-Saharan Africa has made so far?
Thank you so much. The milestone have been a bit good, but if it is excellent, we will not be saying what we are saying today.
So where are the areas we have made progress?
Yeah, where we need to touch, is that before you think about progressing well, you must think of what the advanced countries of this world are doing that you are not doing in Africa. And I can bet you that one of the key areas where we are neglecting, or is on the issue of environmental manipulation. This is one of the key areas the advanced countries of this world have used to fight so many communicable diseases.
What
do you mean by...
Dr. Okafor, just one moment. I'll have us talk about this environmental manipulation in a moment. But first, let's look at the place and points where we have had successes. What are some of the things that we have done right over the last 2 decades as far as malaria is concerned?
Okay, there are so many of them. In Africa now, only 2 countries are certified, free from malaria, Algeria and Morocco. But a whole lot are being done. We've heard about bed-treated nets being given to so many people. We've heard about indoor and outdoor, spraying, but the only thing is they may not be 100% adequate, or maybe followed or strictly followed, Then we've heard about issues of good medications, particularly on the issue of maybe under 5 children and pregnant women. I think by and large, we've done quite so well, on these areas. But I still believe that maybe as we progress, we'll be able to look at the shortcomings of some of these methodologies we are employing. because if some people can be certified free, I believe that more can be done so if we follow the right method and procedures.
So let's look at some of those shortcomings. I'll start with you, Dr. Noble. What are some of the shortcomings or challenges associated with what appears to be a stagnation in Africa's progress?
Like you said earlier, 4 countries so far has been shown to have a high incidence in Africa for having malaria. That's Nigeria ranking highest with 31.3. Then the Democratic Republic of Congo at about 12.6. But I'll drag us back to 2017. As at 2017, we also had 4 countries, but this time around we had Nigeria, we had the Democratic Republic of Congo, we had Mozambique, and we had Uganda. But as at last year, Mozambique has left us, Uganda has left us. They have been replaced by the Republic of Tanzania and Niger. So the places we need to strengthen, as said earlier, is the area regarding vector control against malaria. That includes long-lasting insecticide-treated nets, indoor residual spraying. The thing is, as technology, medicine, science keeps evolving, these mosquitoes, they keep evolving as well. Their behavior changes. So you realize now that they are not biting when it's late at night. They are biting in the early hours of the evening where you're just sitting out with your family, discussing about your day and reminiscing about a thing or two. So their behavior keeps changing, and our attitude towards them has to also keep changing if we have to achieve any form of control. Algeria and Morocco so far, I believe they have done excellently well in eliminating it, and I strongly adhere to the point where we can achieve that if we can strengthen some of these lapses. Like I said, vector control against malaria, that's the indoor residual spraying and the long-lasting insecticide-treated net. Then the right diagnostic testing. These days we have scenarios where people say, oh, when I have this bad dream, I have malaria, it has to be malaria. But we also have non-malaria fevers, So it doesn't just end on our guts. There has to be a parasite-based testing, which is either through a microscopy or through a rapid diagnostic testing to be sure the cause of the fever.
We'll talk more about that in a moment. I'll come back to you, Dr. Okafor. You mentioned the environmental manipulation being one of the things we should look at in Sub-Saharan Africa. Speak to us about that.
Yeah, what I mean, if you look at environmental manipulation, it is a way whereby you design your environment, to prevent some infectious diseases from getting to you. For instance, when you look at so many countries in Africa, we are having canals everywhere, but in those areas, canals are meant for dumping of refuse. Canals are meant for dumping of waste. If you go to advanced countries of the world, canals are meant for as waterways where clean water flows. And inside that canal, they still employ even the biological control, whereby they can put certain species of fishes, like top minnows, gambuzas, and these are fishes that can feed on some of the stages of this parasite. And by so doing, you end up eliminating them. So there is no way you can do without cleanliness. My colleague said something about rapid diagnostic kit and microscopy. Excellent. Very, very important. But I want to say something here. If you must use rapid diagnostic kits, you must have to correlate it with the findings you have with the standard methodology, which is the microscopy. You understand? So many rapid diagnostic kits are not working. People use it for nothing. You can do things like 200 tests without even getting maybe 5 positives. So until you correlate it with the results you get from the microscopy, which is a standard method, then you are sure that rapid diagnostic kits are working. So this might be some of the reasons why so many people are getting false negative results in their testing.
Both of you have mentioned this. Is there a reason the RDT does not work? The self-test kits do not work. What is the reason?
One of them. One of the main reasons why some of them do not work is that people that import these kits do not pass through the normal procedures. In advanced countries, you know, when you import a particular kit, it's supposed to pass through the screening of the body that's supposed to screen or monitor the, you know, how the efficacy of such diagnostic kit. For instance, in Nigeria, you have the Medical Laboratory Science Council of Nigeria that is supposed to look at those kits before they are even imported. You understand? So if it doesn't pass through normal quality control, you might end up importing something that is next to nothing. You know, and it is not everybody that knows how to do microscopy. You understand? If you are not qualified to run microscopy, you might see an artifact, you call it malaria parasite.
I want to talk to Dr. Noble now. Dr. Noble, how much of the adaptability of the vector is responsible for the fact that, you know, you could have these malarial symptoms, yet when you test, it will tell you it's negative? How much of that could be responsible for this, the false negatives? Dr. Noble, that's for you.
Like we said about quality control of kits, as we talked about quality control of kits, we also have to remember that 5 species of this parasite are known to cause malaria in humans, but only 2, that's the Plasmodium falciparum and the Plasmodium vivax, have been known to cause life-threatening symptoms. The rapid diagnostic testing kits, they are sensitive to 95% for Plasmodium falciparum. So what happens to Plasmodium vivax is also a known cause of malaria symptom in this part of the world. So sometimes we try to align our thinking towards only Plasmodium falciparum. The diagnostic testing kit, the rapid diagnostic testing kits, checks for the antigen. It doesn't just rely on fever and some other non-specific symptoms. So there's a likelihood that we may be getting a negative because the causative agent in that particular individual may be a Plasmodium vivax, not a Plasmodium falciparum. But the mainstay remains microscopy. However, the rapid diagnostic testing can be used as a first line in combination with symptoms, presence of a fever, and we use the microscopy as a confirmatory diagnosis to match our basis of treatment.
Very well. Do we also have an accessibility problem regarding these testing kits? Dr. Okafor, would you say?
Yeah, obviously this is Africa, and you cannot rule that out. You know, again, it has to do with maybe who are the people providing it, who are the people supplying it. You understand? Because if it is government supplied, possibly it may be easy to get, which is what we are saying. You know, if you want to eradicate certain diseases, at times government have to show a true color of being a government. You understand? By doing that, you can make a lot of things available. I can tell you that if in our country today, you know, government step up the principle of getting some of these, you know, kits, you understand? If they get some of these kits, you know, and make it available to hospitals, you know, and laboratories, that would be very, very good, you know. But what I'm still saying is that, you know, the accessibility is okay, but it needs to pass through the right procedure to make sure that anyone you are importing is okay and free to go, you know, as a good kit.
Very well.
If it doesn't follow such procedures, you may not be able to get what you want.
Dr. Noble, the WHO identified that low to no income families and individuals are at the southern end of, access or affordability of test kits and treatment. How can we help people, empower people to make sure, to ensure that, look, they have accessibility, they can afford this, and they can also afford treatment?
Yeah, in respect to accessibility, we have a whole lot of hard-to-reach communities in Nigeria, different states, different communities. Some, it may even amaze you to know that they have never even seen an insecticide-treated net. Sometimes they see it and they wonder what it's even used for. Some even use it for something else. So the government has to strengthen their influx of making these nets available. Non-governmental organizations, individuals, all other private-owned organizations. It's not just for us to achieve any kind of win or progress. We shouldn't see it as a government thing. Every person has a role to play. I have a role to play. You have a role to play. The next person has a role to play. If we take it as a common problem or a global burden, I believe we should be able to cut down on some of these assets and making them readily available. We can collaborate with NGOs, collaborate with primary health centers, and ensure that when these materials are provided, they are not sold. On some of these items, we see not for sale. But of course, we know the country we live in. Some people will divert and misuse some of these nets when they even have access to it. So there should be a regulatory body. If we are saying we have provided 1,000 nets, those 1,000 nets have to be accounted for. If we have provided 1,000 diagnostic testing kits, following training of individuals to carry out those tests, they should be accounted for. By the time we start holding people responsible, I believe we should achieve something.
Very well. Now, Dr. Okafor, I want to talk about, stay on accessibility and affordability of the test kits and, treatment thereafter, and the disparities associated with this. Dr. Noble mentioned hard-to-reach areas, conflict areas like we have in Nigeria and in many other parts of the continent. Now, how would you advise governments and development partners to go about reaching these areas with the needed, kits and materials for the fight against malaria?
Thank you very much for that question. It is easier said than done. I believe that why I'm still pointing towards the government is that so many factors militate against, the achievement of or maybe progress in eliminating some of these scourge. You understand? You need an maybe atmosphere of tranquility. If you have strikes all the time, and if you have wars, if you have maybe problems within regions and stuff like that, maybe within a country, you don't expect accessibility. Nobody will go into a particular place where his or her life will be threatened just because they want to save life. So I still believe that government has a role to play in bringing tranquility in the country, bringing peace and unity in the country. You can only achieve some of these things in an area of peace where people, can easily move into different areas of the country. There are places in Nigeria you cannot reach today, no matter how humanitarian you may like to be. There are places you cannot go. You understand? So we have to bring that into focus. So in as much as healthcare providers want to serve, or want to do some certain things, they must do it within an atmosphere of tranquility. I want to mention something here. Why I will always say that government has a bigger role in this problem.
Right.
I will advise in a possible management in the training of more personnel and encouragement of more personnel to rural areas. How do you do that? You don't encourage people to rural areas, except you encourage them. If you encourage somebody to go into the rural areas, you know what to do. First of all, provide safety, provide area of tranquility, provide assurance that he or she will be safe when he gets there. then you see professionals moving into areas, that all those kind of areas you can think of. Let me give you an instance. For instance, in Zanzibar, where I am, Zanzibar is within Tanzania, but Zanzibar is approaching zero prevalence level. Because just like the doctor said, a lot of things you see, that militate against the prevention are being managed. You understand? You bring treatedness, everything will spread to the nooks and crannies of where they are needed.
Right.
You understand? You come here, you see within a year, the health, public health personnel will visit your home, for indoor and outdoor spraying.
Very well.
Because
now,
you think about.
Unfortunately, we don't have a lot of time, so let me give the last word to Dr. Okafor, Dr. Noble. Dr. Noble, tell us what we can do with our women and children regarding protecting them, considering they are the most vulnerable group where malaria is concerned. What can we do to protect women and children?
I like the point that we had to look into the aspect of those who are at a higher risk. We talked about infants, children less than the age of 5, people living with HIV, people who have low immunity and going to areas that are endemic for malaria. We're looking at migrant workers and travelers. But like you said, I would like to talk more about the women and the children. In any context we put them, they are the most vulnerable. So there has to be a conscious effort to making their lives bearable, creating schemes, creating empowerment programs where they also make their voice heard. They can have access to some of these things. By making them empowered, they go into the grassroots and can cause a further spread of prevention.
Very well. Thank you, gentlemen, for your time here on The Square.